Okay, Mary, do you want to get us started?
Yeah, absolutely. Welcome, everybody. My name is Mary Jones. I am chair of the Kansas Mental Health Coalition's Parity Committee. Thank you for joining us today. We're really excited to continue the Mental Health Parity series to keep up to date on perspectives on how behavioral health coverage and is working under insurance rules and regulations. Our goal today is to really highlight what happens for substance use disorder treatment and coverage like to kick this off by having our panelists introduce themselves. One of our panelists did have to step out real quickly, so I'm going to hand it over to you, Kevin, for your introduction.
Perfect. Thank you very much, Mary. Kevin Kufelt with Johnson County Mental Health Center. I am the Director of Addiction and Residential Services here. So I oversee our Adolescent Center for Treatment, which is a residential drug and alcohol provider for the state. I have an outpatient adolescent program. I have an adult detox unit. I have an adult crisis center, an adolescent crisis center, and we'll be adding respite services here soon, along with additional IOP dual diagnosis program. So lots going on here in Johnson County, but happy to be a part of this panel today to provide you all with some of what we're seeing with regards to mental health, behavioral health, substance use treatment, and some of the challenges we face day in and day out.
Thanks, Kevin. I'm Amy Campbell. I work for the Kansas Mental Health Coalition. I am the coalition's lobbyist and coordinator. Just to start out today, if you will put in your questions in the Q&A option, that's very helpful to us. We will hear from our panelists for a short period of time, and then there is an opportunity to get your questions answered. Please know that this seminar is being recorded and will be posted on the Kansas Mental Health Coalition YouTube page for folks to view later. So be aware of that. I did want to just say very quickly that the Kansas Mental Health Coalition has the Mental Health Parity Committee. That committee is open to members who are interested in these topics, and we meet once a month. This last meeting, we had our annual meeting with the insurance department and the commissioner of insurance, Vicki Schmidt, and her staff to get kind of an update on what they were seeing with mental health parity and behavioral health services in Kansas. And that was very useful. So if you feel like that is something you would like to be involved in, please reach out to me. I will put my email in the chat so that anyone can reach out to me if you want to get connected with that committee. Steve, would you like to introduce yourself?
Yes, sorry for coming in and out. When you work at a mental health clinic, sometimes stuff happens. So thank you so much for having me. I'm Steve Denny. I work at Fort County Mental Health Center. I'm currently the deputy director. I've worked several roles over the years. I've been the clinical director. I've done crisis services. I've supervised our SUD, alcohol and drug treatment programs, and I've been with the organization for 20 years. I also serve as the public policy chair for the Kansas Association of Addiction Professionals. I live here in Southeast Kansas, located at Independence. We serve a 5-county area here in our region.
Great. So, Steve, I think we thought maybe you would kick us off here to talk a little bit about what you're seeing in the substance use treatment field, and in particular, issues surrounding health coverage and perhaps some parity issues.
Yes, thank you for the opportunity to speak once again. You know, I've been involved in addiction care in some role or another, really since 2005. Through a lot of different windows. I've worked with older adults, the 65 and older population. I've worked with more the corrections population, general outpatient, certainly crisis services. And they're all challenging. All have had their own challenges and successes. You know, some of the things that really came to mind as we were talking about this as a topic is just the nature of our system. One of the things that's currently challenging about our alcohol and drug treatment system in Kansas is that so much of it is oriented around people that have had legal issues. You know, they've been arrested, or there's been a DUI, been some sort of event resulting in, you know, the involvement with the legal system. and which is good. I'm glad we have systems built around that. It's very much needed. It is not, however, designed around someone in the community, maybe a family member or a friend, someone who's actively employed or engaged in just general community stuff to come in and receive care on a routine basis. And there's different reasons for that. Stigma is a factor, a lack of education and knowledge, resources are a factor. But parity is a factor in that. If you are someone that has I'll just say a regular commercial insurance plan, there are not a lot of options, and sometimes when there are options, there's a process of getting those services approved. There's issues with the rate, and you have a contract with that particular commercial provider. Sometimes there may be an issue with an employee EAP agreement that can get in the way, but there's just a lot of different things that can get in the way. And when we did our community needs assessment in 2024, right at the end of 2024, one of the biggest areas of focus in our region was communicated was we need more interventions for individuals with substance use disorders, and particularly families when you have a parent or two parents living in a home that are using substances. Many times, that 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 episode progresses to the point where we do have to have legal involvement, and there's more serious consequences, foster care involvement, those sorts of things. It's so important for us to be able to intervene earlier and often, and that's one of the things we're focusing on in our outreach efforts in the upcoming year. So that is one thing. Just our system needs to be more designed towards individuals who want to seek voluntary care. It needs to be more normalized as far as that goes. The other thing that really came to mind is community-based care. As a mental health center and as a CCBHC, we have a lot of resources that we can offer somebody in the community so that they do not need a more restrictive level of care. Things like psychiatric rehabilitation services, peer services, case management services, a lot of different groups and home-based services, housing services. There's a lot of different things we can do. The challenge is that in our system, really Medicaid is the only payer that covers those types of services. So if we have someone with the same level of need that's covered by a commercial entity, we're not going to be able to offer that, or if we do offer it, there's going to be some sort of a payment or a copay that goes along with that a lot of people can't afford. I mean, and often they don't even recognize the codes that we would submit to Medicaid. Like, it's not even on their list because it's a state-based code. So that's something we see that on the commercial side. We see that on the Medicare side. We also see that with our veterans that we serve. Just very limited, coverage plans that allow us to do what we do out in the community. The other thing that came up that's important to be aware of is just the issue of credentialing. When we hire a new provider, the process for getting people credentialed has gotten lengthier. It's getting more complex. It's getting more and more specialized in terms of that work. Used to be we would put someone on a Blue Cross Blue Shield panel, a handful of other insurances in our communities, and that was it. But it has gotten so much more complicated, and there are so many different avenues and windows that we have to march down to get our people credentialed. Sometimes it can take 3 months, 6 months to get someone credentialed to start providing those cares, which creates a backlist, and it creates access to care issues. And the other thing I think is really important to understand is just resource gaps. We serve a rural area. I'll never forget, years ago we were on a call with one of the managed care organizations. This was about a children in need of services, and we are kind of talking about what do we do with this kid. There's a lot of complicated issues happening in this situation, and they were like, "Well, what if you just had them go to the YMCA, 3 or 4 times a week to give them something to do?" And we're like, "That would be great, but the closest YMCA is 2 hours away, and they don't have transportation." And a lot of times there's just a lack of understanding of what the needs are in some of our rural areas. So in our area in particular, there's just a handful of SUD providers. We're the primary provider in our area. There's a couple of smaller shops around, but there's just not there's not a ton of options for people, and what we can offer in an outpatient setting is going to be limited. So if we do have to refer someone to residential or a more intensive level of care, often we're 1 hour, 2 hours, 3 hours away. And we've transported people to Dodge City. We've transported people out of state before. And lastly, that's another thing too. If someone often, they do need some sort of a level of care that is not offered in the state of Kansas, it can be extremely challenging to find beds or to find referrals in other states that the insurance company is going to be willing to cover. That's true on the Medicaid and the commercial side. Often we still have alcohol and drug treatment completely separate from mental health, and what we know is that it often happens in relation to mental health needs and physical health needs. So that's one of the advantages of the CCBHC system, which allows us to look at the whole person. But so many things are still kind of separated in their own silos, and that's an area where we need to continue to get better at integrating and working together. So, and obviously the specific challenges related to specific substances in our region, methamphetamine is still our number one concern. Not that opioids aren't around, but we still deal with meth probably as our number one. Alcohol and marijuana are probably our top three, with opioids on the rise. But once again, just resources for those different needs can be limited, particularly if someone has a commercial coverage, or maybe they're employed and they make just enough money to not be able to be covered by a state plan or assistance in that area. So those are some of my thoughts. I'm sure happy to answer questions or comment further as you need me to. Thank you for allowing me to speak.
Thank you, Steve. Kevin?
All right, thank you very much. I failed to mention that I heard Steve mention, and that is I'm the executive chair with CAP as well. So Steve and I are in regular contact with each other, along with other providers across the state. So we're addressing these issues head on a monthly to bi-monthly basis. So certainly something that's near and dear to all of our hearts with regards to substance use and the treatment and the level of care that we're providing. So my spin is going to be a little bit different than what Steve just provided you, because I'm going to address some of the residential issues that we've endured throughout the years. I will say, when I think back to the 2020 year, when we look at the COVID and some of the positive outcomes of COVID, if I'm allowed to say that, and that was that renewed light on the impact of mental health and substance use that it's had on the daily life of anybody, that nobody was immune to substance use and mental health conditions. And what once was believed, folks who thought themselves to be emotionally stable found themselves drinking alcohol during the day. They were sleeping in later in the mornings. They lacked motivation to get up and go to work. They felt isolated. And maybe even some of them were feeling a little bit depressed too. So COVID kind of brought this almost a crack in the wall when it came to the stigmatization associated with mental health and substance use disorder. So I'm not praising COVID, but I do recognize that while we were in the middle of COVID, folks were being impacted at a level that they hadn't seen before, which kind of opened our doors a little bit wider too. So what we've seen and kind of what we continue to see is that, yes, it is true, and Steve pointed this out as well, is that there are many individuals who experience substance use disorder and also have another co-occurring diagnoses. And unfortunately, many organizations are prone to really identifying that mental health diagnosis first as a means to kind of get them in the door and to initiate that care. And then they can later refer to SUD services. I will tell you that with Johnson County Mental Health, we've worked pretty hard to recognize that gap in care, and that there are individuals who are seeking substance use treatment may not have that mental health diagnosis. And so 5 of my programs in my division do not require the admission process going through open access, that model that's in place. And we've really designed it so that individuals who are experiencing a substance use disorder can still gain access to the treatment without having to jump through some of the different hoops that may be involved, that they may not qualify for services. So really working hard to get folks with a substance use disorder into treatment so they can get that level of care too. I think it's also important to note that many substances mirror that of mental health symptoms. So when you look at the brain's response to Steve mentioned methamphetamine. Methamphetamine mimics that of mania. The brain's response to cannabis mirrors oftentimes anxiety. And when you look at alcohol, the brain mimics that of mood swings and lowered inhibitions. And so when you when you couple that along with even looking at someone who is withdrawing from these substances, you start to see depression, you see irritability, you see amotivation, you see anxiety, you see all these mental health components that are truly tied to a person's substance use. So I think it's important to note that although we're advocating for both mental health and substance use parity, there's a lot of things that are associated with substance use that often can go overlooked or not associated with each other. So the challenges that we face. So what I'll do is I'll provide you an example as it relates to, let's go with youth entering into residential drug and alcohol treatment at that residential level of care. So we might have a youth that is entering, we'll use ACT as an example, who have experienced an intensification of their substance use. And this has occurred despite having legal system involvement, poor engagement in outpatient services. They're testing positive for urine drug screens. And not to mention, they've completed this 6-dimension biopsychosocial assessment in which their clinician has identified that they now need a higher level of care, that they've been unable to maintain a level of sobriety or decrease their use at the outpatient level. So when that youth arrives at a residential facility, they're seen by a clinician. They complete initial intake diagnostic assessment. That clinician will review and make updates to the SUD assessment, and then they will provide that insurance company with, I guess what you could call would be a justification for a level of care. That insurance company will then call the clinician back asking maybe for some additional information, and then they'll want to oftentimes speak to the attending psychiatrist because they want to do a peer-to-peer review. In many cases, our psychiatrist isn't available for those reviews, so immediately that claim can be denied because they haven't had a doc-to-doc review. And then they might start recommending a lower level of care for them. And now if they do authorize care, if they say, okay, yeah, you got Kevin into services, we're going to authorize 5 initial days of treatment for you, an opportunity to kind of stabilize him and get him ready for discharge back to his home community. So when they want that call in 5 to 7 days with the expectation that Kevin's going to return home. What we found at the residential level care is we have youth coming in from across the state. You give me a kid who comes in who's a fentanyl user and they use that morning or they use the day before, we're going to experience they will experience some severe withdrawal symptoms as they're now at the residential level care. Those first 4 or 5 days of treatment are a kid experiencing severe withdrawal symptoms. We haven't stabilized anything. We've met with them. We've got them in to see the clinician. They might have attended a few groups here and there, but they're by no means prepared to return back to their home community. So, if I asked any of you in this room today to stop drinking coffee in the morning for the next 5 days, and that all of your problems would go away, you'd probably laugh in my face. But that's essentially what these insurance companies are asking us to do. Get them into treatment, and in 5 days, get them back to their home community because you've stabilized them and they're now ready to return back to that lower level of care. It's not magically going to go away. And I oftentimes think of that long-standing comparison when we talk about diabetes and heart disease. If we put a patient in with diabetes to see their doctor, they're not cured in 5 days. This is an ongoing procedure, it's a practice that needs to be involved. And so that's what we are arguing with even the residential level of care. We can't cure these kids in 5 days. They need prolonged levels of care. They need intensive treatment. They need to be going to individuals and groups. They need family involvement. There's a lot that goes into providing substance use treatment. Now, oftentimes Medicaid will provide 14 days up front with a continued stay review on that 14th day. So we've had about a 2-week span in which we can provide some of that foundational work with a youth on recovery counseling as we then start to venture into relapse prevention. The block grant provides 21 days up front with a review for additional 7 days after those 21 days. So those are cases in which we can go into the system knowing that we're going to be able to provide treatment to this individual and start working towards that discharge back to a lower level of care. But really with some of the private insurances, we don't know that we're going to actually get paid. They may even authorize the level of care, but that doesn't necessarily mean that we're going to get paid for the services that we provided. So I can tell you that one thing that used to really frustrate me when communicating with the private insurance organizations was that I might be speaking to a utilization review team member that's located in California or New York. And when I inform them that, hey, I've got Kevin here, he's a 15-year-old daily user of cannabis, their response is almost like, and? It's like, well, we got a 15-year-old that's prone to having maybe a co-occurring disorder, and they're now using a substance, today's cannabis. If you've watched the news or read any of these medical journals, you now know that cannabis concentrates are upwards of 70, 80, 90% THC levels. That linkage between cannabis use and drug-induced psychosis is becoming more and more prominent as we look at the numbers. And they're correlated with early onset, the frequency and the amount of their use, and the high potency concentrates of cannabis. So whether you're talking about edibles or waxes or butters or oils or vapes, we're talking a high potency level of cannabis use that, when introduced to a growing adolescent brain, is going to have drastic effects on them. So we know that these problems, if left untreated, they're going to create even more intensive emotional and behavioral problems if we don't provide this level of care. So, at some point, we're going to have to look at, what the standard of care looks like. And if we have to continue worrying about having to justify getting an individual into services because they may not meet what they believe is their criteria, we're just going to continue to flood emergency rooms. There's going to be people spending unnecessary amounts of time in detention centers and jails. And we're just going to see this higher rate of overdoses and unsuspected poisoning. So I could go all day into the impact of substance use. You heard Steve talk about methamphetamine use, alcohol use, and cannabis use being those top three. The same is pretty true with the adolescent program with regards to not necessarily being methamphetamine. We see that more in our adult population as well. But opioids, yes, they are somewhat on the decline, but we're still continuing to get youth coming in that are being cross-contaminated, whether they're using Percocets or hydrocodone. We worry about the use of Xanax and ecstasy all being infiltrated with fentanyl use, but we know that a high percentage or majority of these youth coming into programs are abusing high concentrates of THC. And whether you want to go into the school system, go to the park, go walking down the street, you're going to find youth that are carrying around THC vape devices that they now have this misconceived notion that because they're vaping, that it's not really that harmful for them. So this is an ongoing battle. This is not something that we've mastered or overcome. We will continue to fight the battle, but we need to be able to get these folks into services and into treatment, because we already know that roughly 90% of people with a substance use disorder don't seek treatment. But when we do have this 10% that are seeking treatment, we shouldn't be denying them services. We shouldn't be creating barriers. We shouldn't be creating a whole bunch of red tape that makes it more difficult for them to enter into services. And I'm familiar, don't get me wrong, I'm familiar with the phrase of, meeting them where they're at. I understand that it applies to approaching clients with empathy and understanding and respect for their current situation they might be dealing with. But if we can't get them into services, then how are we truly expecting to help them where they're at if we can't get them in the doors? So those are just kind of some of the examples that I've seen or experienced with regards to providing SUD services in the state of Kansas. And my hope is that with continued advocating for these parity laws and those being enforced both federally and at the state level, that hopefully we can kind of create less barriers and less red tape for individuals who truly need our help. So sorry I went on a little bit of a rant there, but that's kind of what we see day in and day out. But as Steve said, I'd be happy to sit for some questions, and hopefully I can provide answers to those as well.
Now, just to kind of kick things off, I think you were right on the edge of kind of talking about this, but let's kind of divvy this up into adults and adolescents. What is your ideal partnership with a third-party payer when an adolescent is seeking to come into services? What do you think that process could look like that would be constructive and most useful to getting them into the services that best suit them?
I think what would be important is that they understand the types and levels of care that we're providing, and that we are CARF accredited. We're CCBHC. I've got KDADS that comes through on almost a biannual basis. I've got DCF that comes through. I've got SB 123 that comes through with KDADS. We always have someone looking under the hood. And I think if the commercial insurance and private insurance companies understood what type of service delivery that we're providing intensive individual, group, family. We've got all sorts of level. We're using evidence-based practices, evidence-based curriculum. We're providing the most comprehensive level of care that an individual, a youth coming into services, needs in order to assist them in developing a better understanding of their substance use, their emotional behavioral issues, and doing our best to prepare them back to return to the home community. So I almost wonder if they don't understand to the extent of what level of care we're providing. And we've got med providers involved. We're looking at MAT. We're trying to provide them with medication so that they can help curb the cravings and the withdrawal symptoms, and providing them with that next level of care, and then ultimately discharging them back to their home communities and setting them up with those same levels of care at the outpatient level, along with engagement in community-based support groups. So I guess my best answer is they need to understand what we're providing and how we're providing it.
So you're basically saying it would be nice if the third party payer had a better understanding of what is the standard evidence-based treatment that should be occurring in a variety of cases that you might see, that it's individual. And that's probably the same for adults as well, then. The same thing is what you would be looking for there. Steve, do you have anything you want to comment on that?
Yeah, I would just add that accessibility is important. So if the fewer barriers we have to get a provider credentialed, so we can start providing care more quickly, so we don't have a more restrictive limited provider panel. So that would be step one. The step two would be we'd like to be able to offer the same services and pull everything out of our toolbox to be able to help people that we're able to do for individuals with Medicaid. We just don't have those same resources, peer services, case management, community-based options that we receive reimbursement for Medicaid that we just can't do on the commercial side. Because I think there's a lot we could do as a system to be really effective with those individuals, but we're just so restricted in what we can do because they don't even recognize some of the codes that we would use on the state side of our business. So to me, that would be the ideal relationship, is we could have the same set of resources and tools that we would offer someone that has Medicaid, or even someone that's on our uninsured state plan that's managed by Carillon or Beacon. That would even be good. But once again, a lot of those services aren't available.
Well, my second question has to do with what does that ideal recovery path look like? Let's talk about adolescents. And obviously, I'm asking you to generalize. We understand that those needs are very different depending on the individual. But in a typical scenario, what are you looking for when you are looking for a pattern and a wrapping around a certain amount of care that's going to be most likely to be successful for an adolescent?
I think what's important to note with a youth returning back to their home community is that they have to return back to that home community. They don't get to make decisions as to where they're moving, who they're living with. They move back to that home. And some of the complexities of some of these kids are returning back to home of families who actively use substances. So they're already kind of being put into a position where the risk for an immediate return to use is high. So they have to deal with that. But I'm getting ready to launch another an IOP level of care for youth. There's not a lot of IOP services, intensive outpatient services for youth, even in Johnson County. You think that Johnson County would be able to provide that level of care more readily available, and it's not available. So we'll be providing more IOP services. So really, an ideal scenario would be if a kid is in a level 1 outpatient services, not meeting that need, we can bump them into IOP, more intensive level care. If that doesn't work, then we pop them up into a residential. Once we complete that residential level care, move them, transition back down to IOP, and then back into a level 1. So we haven't met that need yet, and we need to be doing so. But the ongoing collaboration, whether it's with court services or community corrections, the mental health center, and and I guess another piece would be with that there's not a lot of options for youth in the community-based support groups, whether it's AA or NA. They don't have a lot of options available that they can relate to. You give me a 16-year-old kid with a substance use problem, and you introduce them into a community-based support group, and they said, oh, these people are all really old. They're like 50. Well, they're not going to relate to them, and they don't feel like they relate to them. So then they stop going. So I think another component is the school districts used to really welcome the mental health center in there to provide some of those community supports and that substance use support. They've moved away from that as well. So from the school setting to the court services to community corrections to the mental health center, I think this ongoing collaboration needs to kind of be revitalized.
Steve, do you have anything to add to that?
Yes, I think, could you repeat the question?
I was just saying, what is the sort of the ideal recovery setup for an adolescent coming into services?
Yeah, so one other additional thought that came to mind, as particularly on the commercial side of things, they have connections with primary care. And I think that is part of this equation is more effective integration between behavioral health treatment and primary care. I know there's a lot happening at the state level talking about that right now, but the ability to, empower our primary care providers with the ability to do screenings to more effectively be able to address, substance use disorder conditions, at least at a basic level to get them the services they need and to have some follow-up medical care. Because a lot of folks with substance use disorder conditions also have, pretty serious health consequences and their medications interact and those sort of things. So that would be important. The other thing I would say is I think it's important to understand with addiction treatment that part of it is what's happening in the community when they get back. So people need access to transportation, they need access to housing, they need access to employment. So the ability to have the opportunity to connect people with those things through more case management, care coordination type activities, those take time, energy, cost, all of those things. We need more, need more ability to address those things through care coordination. But also, I think most importantly, a treatment provider is not going to fix this thing, if that makes sense. And I still think plugging people in the community, whether that's, your support group community or faith-based community, whatever that might be, we still have to have those connections at the community level because there's a lot of different pathways to recovery. Like there is not one single, this works for everybody. Everyone's situation and circumstances is different. So community integration and community resources are really important. And that looks different, in every community.
And what about the idea of people coming back into treatment? I've certainly had my own experiences through acquaintances and family where there wasn't one trip to a recovery center that helped them to really get their entire lifestyle revamped in a way that they were able to be successful the first time around. Does that create problems for you when it comes to the third-party payers and getting people back into services or replugging them in maybe at a different level?
Well, I don't know that I've seen any major issues with it. I think it's one of the things that we're cognizant of is that if we discharge an individual and they return back to use, the likelihood of them being approved for coming right back in is I'd say it would be lower because they ultimately would be considered having not put forth the skills or the tools or the referrals to practice. So I don't have any concrete evidence that says it would be more difficult to get them approved. I just think that we know that it does take multiple stints of treatment to be successful. We know that that's the case. Again, if I said you couldn't drink coffee this week, but you had to stop for the rest of your life, you most likely start dabbling back in some coffee next week. So we don't identify one individual as being, well, you've already had treatment, you can no longer receive services from us, because we know it's going to take multiple stints. We see folks coming through our social detox program multiple times throughout the year, and we're going to be there treat them with the same care, dignity, and respect that they require to get them back on their feet and get them and relay them back to other services, whether that's residential or outpatient services. And to Steve's point, we need to wrap the community around them. A lot of them are dealing with housing issues, and we need to help them with that. They need transportation issues. They need case management. We will not stop providing care and treatment folks just because they've had multiple attempts at services. So that's what I got for you.
Something else to add to that too. I was just thinking if one of our medical providers, one of our physicians was on this panel today, I think that he or she would talk about prior authorizations and just the incredible challenge that exists around getting medications approved so that they can be prescribed in a timely manner and we can start intervening. Now on the addiction side, there's fewer medications, but certainly it comes up, whether it's for alcohol or an opioid issue or even a smoking cessation intervention. Prior authorization is a challenge, and we almost have a full-time nurse doing nothing but managing prior authorization. So she's not spending time checking blood pressure. She's not spending time checking vitals. She's spending time trying to get medications approved so they can be prescribed most of her time, most of her day. And that's something that I think would definitely come up, as well as that we can improve things as far as our medication pathways.
We have a question in the Q&A. Are you finding that the substance of choice impacts the ability for the client to access treatment services and or the payment for those services? Does it make a difference what the substance is?
I'll tell you that when we're talking about youth with fentanyl use disorder, it's almost like it feels like it's more of a green light, and it's almost obviously we have folks who are whether they're pregnant or IV drug use. The IV drug use kind of puts them to the front of the line there, but fentanyl and opioid use is certainly one that has an impact on what I perceive would be the immediate approval. But I've seen that cannabis use has been more difficult to get approved because they don't view it. The stigmatism of cannabis is decreased, so they don't view it as that dangerous of a substance. So that's kind of what I've seen throughout the years. But certainly, we will make a case for that. Many of our clients don't just use one substance. There's oftentimes multiple substances that they're abusing at the same time, which also places them at a heightened risk.
It's a complex question. I mean, you think about meth and cocaine; they're both stimulants, right? One's associated with probably a different social class than the other, and I certainly think that does come into play from time to time. I don't know that it's driven as much by the substance, but certainly the resources of the individual who's using that substance is certainly a factor, But I agree with what Kevin said. There are certain ones that are just harder to get traction on.
And to the point, I'm looking at the chat right now, and I see Chad. He's being a little silly with regards to coffee with the dark chocolate and protein bars, but we see drug substitution going on all the time. You can drive down the road and see that you can get kratom or you can get CBD, and folks have this misconception or this misperception of I'm getting rid of my dangerous drug and I'm going to something that's more socially acceptable and something that's quote unquote legal. That's still causing problems because when you look at kratom use, whether it's a high dosage or a low dosage, you're looking at different symptomology, whether it's a depressant or a stimulant. So to wrap your head around some of these new synthetic types of substances doesn't make them safer. It makes them almost potentially more dangerous. And then we're trying to have conversations with insurance companies about kratom use. And where does that fall on their criteria for approving treatment for someone who is no longer using, let's say, cocaine or methamphetamine, but now they're using kratom as a stimulant. So there's some complexities there as well.
So you bring up an interesting point there, because the statutes say that a commercial insurer does not have to cover their member if the treatment is court ordered. Is that correct? So if it's a legal substance, it wouldn't be a court ordered treatment situation. So, I mean, there's a lot of complexity that comes in. I think for a family member who's trying to make sure that their adolescent or their adult child is getting services, some of these rules seem nonsensical.
Well, and I can tell you one thing that we've done for many years is that when we have close communication, coordination with the courts, the judges are often making a recommendation or a referral for residential level care. So they're saying, go get an assessment completed. Whatever that assessment recommends, that's what you need to comply with. So it's never, from what I've seen, it's never really been a court ordered, you need to go to residential level care. It's a court referred to a provider for an assessment, and you will need to follow those recommendations as outlined by that professional. So I'm not saying it's kind of skirting the system, but I'm saying they're relying on us with our professional opinion as to what level of care this individual is requiring. And from there, we look at recommendations for whether it's an IOP level care or a residential level care.
So there's a question in the Q&A, and it's more about the sustainability of the provider system. Have CMHCs or CCBHCs been able to diversify their payers and commercial insurance to help with the sustainability of the clinics themselves over the past decade?
I would say no.
Yeah.
And what I mean by that, we're heavily relying on Medicaid. Commercial and Medicare really kind of vary depending on where your community is at, what your population is made of, what your resources are. And here in Southeast Kansas, we've had 2 or 3 major companies close in the last 10 to 15 years who were significant suppliers of commercial insurances. So our uninsured rate has gone up significantly. Medicare is really contingent upon the age of your community. So we see a little bit more Medicare than in our area because we have more individuals, but Medicare doesn't pay at the same level that Medicaid does. So we certainly bill all payers, and we certainly try to utilize all payers. But as far as equality amongst those payers, we're very heavily dependent on Medicaid and state-funded plans.
And I really don't have anything else to add other than what Steve just mentioned. So I'd say we're pretty similar in that regard. I don't have any data to share with you today, but I would certainly look into that more thoroughly if you'd like for more information from us.
And kind of along the same lines, there's a question here. Is there a fiscal benefit to the CCBHCs if community prevention programs are more effective? Or does effective prevention limit or have a neutral net benefit toward the sustainability of treatment providers?
I think it does, and Kevin, feel free to jump in and add whatever you think. But the one advantage of CCBHC is, it's based on your community needs assessments. We're able to tailor what we do around the needs of our community based on data. And there is some space for creativity to think through what are the types of programs and services we need to reduce more restrictive and costly levels of care. So one of the first things we did was develop a assertive community treatment plan. And now all the other folks, assertive community treatment program, ACT program, focusing on those with the most significant needs, addiction and mental health, who often don't fit into other programs and services. And we've been able to see a lot of people not utilize it as many higher cost services. You can do early childhood types programs and services. So yeah, I definitely think there's some longer term opportunity with a preventative angle. Once again, we're not the end all be all. There's just got to be community engagement, but I do think there's opportunity. And I think we'll see that as the model progresses over the next 5 to 10 years. There's definitely some flexibility to address some of those preventative, concepts on the front end more than we have been in the past.
Yeah, my only comments I'd add to that is that we know that prevention works, and we know that there's been probably a decrease in funding across the state for preventive services. And if we could get into the settings, into the school, into the community more frequently and providing more preventative care, it obviously have a decrease in the amount of higher levels of care that would be required. So what I've learned throughout the years is, back in the day, we used to target high school students. We used to get into the schools and talk to those high school kids. And then it turned into, well, we really need to get into the middle schools because the age of first use is decreasing. So we got to get those 8th graders before they get into high school. Well, now we know, state of Kansas, I'd say average age of first use with any type of substance, whether that's nicotine or even cannabis, we're looking at 12, not quite 13 years of age. So at what point in time do we really need to start getting into the elementary schools and talking to those fifth and sixth graders that says, hey, this is a substance you need to be aware of. This vaping product is not a safe alternative. This is if we can prevent them from getting engaged in those high risk behaviors, we stop it early. We can't control social media. We can't control TikTok and what the new growing trend is, but certainly we need to be out there in front of things to the best of our abilities to stop them before they become a major problem.
There's another question here. You've talked about the difficulties with credentialing. Do you have any policy recommendations that you think would be helpful with that?
I would say kind of, and I say that because I'm not an expert on it. I know what I hear from our billing staff and our credentialing provider who does a lot of that work just in terms of the challenges. My initial thought is some sort of universal set of standards. You know, if I provide data points A through Z or whatever those data points are, that those are accepted across multiple panels. It's very unique and individualized across, you know, all the different provider networks. So that's where the complexity gets in. And I think also accessibility and availability on the other end. Sometimes it's hard with some insurance companies to even find a human being to speak to, you know, when you run into some of these challenges, and there's not one available, and that can be really challenging. So I think the more, you know, when we can centralize and have a standard set of data points that are required for credentialing, and that's kind of universally accepted, I think that would help. But I can definitely get some specifics on that from our team and send that to you, Amy.
One of the behavioral health parity standards that is discussed across the country by policy folks is the issue of their networks, their provider networks, and that if they don't have a robust provider network of folks who are actually accepting patients, then they're not meeting their parity requirements. I wonder if more scrutiny on provider networks wouldn't urge expediting some of this credentialing as well.
Good thought. Or at least taking a lay of the land, doing an assessment of what that even looks like. Because I think that would, to know where we stand with that would be useful, I think.
Okay, so please speak on the parity of problem gambling and current diagnosable SUDs, considering the use of state-owned gambling revenues that are funding crisis services, and if you support this current model for the benefit of those in either problem gambling or substance use. Also, are there FDA-approved drugs for SUD substances like nicotine or inhalants?
Well,
I can go ahead, Kevin. No,
well,
I was going to ask you to speak about the nicotine, the inhalants, and that's more your
yeah. I was going to.
I can talk about gambling if you want me to later on. That's fine.
Perfect. Yeah, thanks. So I would say with regards to with the SUD substances of nicotine and inhalants, I do know, and I'm not a doctor by any means here, but certainly we know of folks who have used Wellbutrin before in the past for helping curb some of those nicotine cravings and withdrawals. So I know that there are some medications out there that prescribers have used for nicotine. The inhalants are so tough because, you know, they're not a tobacco product. They're a fine particle system. We don't have anything that we really offer with regards to cessation programs within a mental health center. The school districts utilize online-based platforms. I know that there's the Can Quit program and providing coaching to folks who are trying to get off of those types of substances. But really, I would have to get with prescribers and talk more about what they would recommend with regards to those, to the replacement of nicotine. At the mental health center, and specifically our social detox program, we offer nicotine replacement programming, whether it's the lozenges or the patches, and kind of help them wean themselves off of those products. We no longer allow them to take smoke breaks on the units. Our whole campus of all of our providers here at the mental health center are now smoke-free, nicotine-free campuses. So obviously trying to promote healthy lifestyles and healthy living. So but we still offer those nicotine replacement therapies to help them get over their early withdrawals and those early cravings as well.
You want to talk about the problem gambling?
Yeah, and actually, I'm trying to think. We do have a problem gambling program. I don't know if we've ever attempted to bill or submit a claim for a gambling use disorder. We certainly have through the state problem gambling program on multiple occasions. So I'd have to kind of look into that. There are CPT codes that do address gambling that we can use to treat that condition. And I do as far as using gambling dollars, tax revenue to help support our services. If we're going to allow it, I think we need some dollars to help to cover the consequences of it. It's the same thing with tobacco or alcohol or whatever, liquor tax. I mean, there's always going to be consequences when you legalize anything that people can get hooked on. So absolutely, I support that. Now we could get into the should it be legal to begin with conversation on a different day, but definitely if it's here, we might as well use some of those funds to help us get, because people don't come in for a gambling wellness checkup. They come in because they're in a serious life situation, and often the money's gone, right? And so they're not going to have ability to pay 99% of the time, in my experience.
And if there are dollars approved for it, we need to make sure that those dollars go towards the treatment of those gambling disorders, that they don't just get pushed off to other programs or reallocated. So we need to make sure that we're taking care of those dollars and that they're going to where they need to be spent too, which I am anxious to kind of see with sports bet gambling going on in the state of Kansas now. And you see it almost on every other commercial if you're watching football or basketball or baseball. It's going to be interesting to see what this next generation of individuals were not gamblers or becoming gamblers, because it's so enticing to win early, and they will give you free dollars to bet on the next round. I think we're going to eventually start to see a negative impact of sports bet gambling going on that will, some folks can do it, try it and win a little bit and then be done. And then other folks try to regain those losses. So it's going to be an interesting development that comes up throughout the next few years.
And I would comment that this summer, the interim Federal and State Affairs Committee did receive an updated report on the prevalence of gambling by Kansans since the introduction of these new forms of gaming. And it was a little bit, that data was pretty significant. So KMHC can distribute that study for folks who want to have a look at it. I'm going to squeeze in one last question. If we had full parity in Kansas, particularly with private insurance companies, how might that impact the public funding that is being utilized for those who are underinsured today?
I would say that the person asking that question can probably answer it better than us. But what I would say is, obviously, I think if we had full parity and then people were able to get care, in an accessible, meaningful, full episode of care, that's going to have an impact. It's going to reduce reliance on those state systems. It's also going to cost more to the individuals funding those private insurance plans and the companies that do that. And that's complex because you have some larger companies, corporations that absolutely can afford those types of plans, and there's also smaller companies that may not have the ability to absorb the costs that those insurance companies would push up at the corporate level. We certainly experience that as an agency ourselves. So it's a complex question, but ultimately I do think we would be less reliant on some of our state funded programs if we did have full parity, because I think we'd see fewer people, getting to that level where they, they're in trouble or there's a legal issue requiring them to enter those systems. And I think it would definitely have an impact in that way.
And if somebody else asked me this question, I would say, who's a good person to talk to would be Deb Stidham. She could provide you some good insight into this. So
I appreciate that. Definitely an expert within our midst. Mm-hmm. So I'm going to go ahead and wrap up. We're pushed up against the 1 o'clock hour. I'm so grateful for everybody who's participated today, and for Steve and Kevin for giving us so much of their time. your insight is just, I mean, I could ask you questions for the next hour, really, just to get a sense of where we are today. It's fascinating to me to hear kind of an inside view of the way that things are going. The Kansas Mental Health Coalition will continue to push for better recognition across systems of the need for behavioral health parity and effective oversight of the implementation of the behavioral health parity laws to take some of the pressures off of these public systems and to make sure that people get the services that they're entitled to when they pay their premiums. So with that, I do want to add that in our meeting with the insurance department, a relatively new development is that this insurance commissioner implemented the ability for providers to engage in appeals processes for people who are trying to appeal denials or deal with barriers to access to coverage. And so the providers are able to engage and provide that information directly to the insurance department now and help with those things. And I share that for the folks who are on this call. If you or someone you know is having difficulty accessing treatment and you're having trouble getting coverage through your commercial insurer, that there are options through the insurance department to help you with that. And we at the Kansas Mental Health Coalition also have information that can be helpful to you on how to engage in that process. So with that, I want to thank everyone for spending time with us today. And I hope you have a wonderful Friday afternoon.
Thank you.